My name is Antonio Marcelino. I work as a radiologist specialized in ultrasound, and I'm going to talk about a little bit about ultrasound Doppler evaluation of liver disease. Doppler sonography in the evaluation of liver disease. My main objectives today is describe the methodology to evaluate the liver using ultrasound Doppler and the main complications of liver disease. Demonstrate different examples of this disease that can cause portal hypertension. Identify the appropriate search for collaterals, pathways, and the use of Doppler sonography in this scenario. And finally, show the use of contrast-enhanced ultrasound in transjugular intrahepatic parasystemic shunts evaluation. Vesalius had already touched on the core of the pathophysiology by describing a case of bleeding hemorrhoids and suggested that this was due to a dilation of the portal branches. The suspicion that gastrointestinal hemorrhage could be caused by the derangement of the portal circulation was passed on 2 centuries later by Morgani. He described a patient observed by his teacher Valsova, who had died from gastrointestinal bleeding and was found to have polypoid concretions in the splenic vein and dilation of the short gastric veins. Here we can see a pictorial by Vesalius of the portal venous systems. Then here we can see everything: the liver, the main portal vein, the splenic vein, the spleen, the intestinal branches, and hemorrhoidal plexus. In 1650, Glisson established that portal vein was as the vessel by which blood was collected from the gastrointestinal tract and returned to the systemic circulation. In 1877, Nicolai van Eyck established the shunt from IVC to the portal vein. Starting the 20th century, Preble collected 60 cases of liver cirrhosis where the patient died from hematemesis, and 80% of them had esophageal varices. In 1902, Gilbert introduced the term of portal hypertension, now universally accepted. Doppler applications. You can use Doppler for the evaluation of chronic liver disease and complications, evaluation of liver transplants, evaluation of TIPS, and focal hepatic lesions. Exam protocol. You need to study using an effective methodology based on positioning and breathing, measurement of structures and vessel diameter. And you can identify the presence, direction, and velocity and flow pattern of main portal vein, the branches, and splenic and mesenteric, superior mesenteric vein. Parameters: power and priority, gain, transducer frequency, baseline, wall filters, velocity of the sample of spectrum, PRF, persistence, focus positions, angle correction, color map, size, and positioning of the sample volume is useful for this evaluation. Here we can see an example On the left side, you can see the main portal vein without flow when you use a wall filter of 100 Hertz. Then, on the right side, the wall filter is positioned in 25 Hertz. Now, with this filter, you can identify the main portal vein flow to the liver. Chronic liver disease. Cirrhosis is about 19%. Budd-Chiari Syndrome and cardiac liver are important too. In Brazil, we have some cases, a lot of cases of Schistosomiasis, then you can see later. Exam protocol. We need to evaluate the main portal vein, right and left portal branches, the hepatic artery, main hepatic veins, splenic vein, superior mesenteric vein, and look for collaterals as Paraumbilical vein, esophageal varices, short gastric vein, cystic varices, and shunts, systemic shunts. Normal pattern of portal vein. On the right, we can see a normal pattern of main portal vein identified in pulsed Doppler, and on the left, the measurement of the main portal vein close to the hepatic artery entrance into the liver. Portal vein changes. Diameter 1.3 centimeter. Velocity less than 12 or, for some authors, 15 centimeters per second. Reversed flow, pathophysiological flow can identified in some cases. Bidirectional flow, two-fro flow, as you can see on this picture, the flow is to and fro the liver. Cavernotomous transformation and thrombosis. Now, here you can identify the hepatophysiological flow in the main portal vein and the hepatopital flow in the hepatic artery. Hepatic vein Doppler. The aspect of hepatic vein is this one, as you can see in this picture. And in some situations, some pathologic situations, we can identify the absence of flow in cases of Budd-Chiari syndrome. You can identify multiphasic flow in normal and individuals with cirrhosis. Portalization of the hepatic vein waveform, as you can see in the middle hepatic vein, in this case, the portalized hepatic vein waveform. You can identify the portalization in post-transplantations and strictures, partial Budd-Chiari syndrome, as you can see later, and some authors detected the portalization of the hepatic vein waveform in cases of Stenosis and hepatitis. Hepatic artery. Hepatic artery had a flow pattern characteristic with a peak systolic velocity ranged from 0.70 of resistive indexes and pulsatility index close to 1.34. There are many indexes described in the literature, but in some cases there is little practical use of congestion of portal vein, hepatic vascular indexes, and arterioportal index. The practical significance of hepatic artery Doppler is used for suspected of post-transplant thrombosis and low resistance flow when we suspect of portal vein thrombosis. Definition of portal hypertension. Portal hypertension is a hemodynamic feature when we identify a portal pressure more than 6 to 10 millimeters or a pressure gradient between portal vein and hepatic veins more than 5. When you have the portal pressure more than 12, the gradient more than 12 millimeters, we identify collateral pathways, systemic collateral pathways. The portal hypertension classification: pre-hepatic blood arrival obstruction, hepatic portal hypertension. Schistosomiasis is an example of pre-sinusoidal cases of portal hypertension. Sinusoidal is caused by cirrhosis, and post-sinusoidal is caused by Budd-Chiari Syndrome. The post-hepatic portal hypertension is caused in cases of pericarditis and chronic heart failure. Portal hypertension diagnostic criteria. Different signs of liver disease on gray scale. Portal vein more than 1.3 centimeter. Velocity less than 12 centimeters per second. Collaterals: splenomegaly and splenic vein or SMA, SMV more than 1 centimeter. Schistosomiasis. There are some features of schistosomiasis. We can identify hepatomegaly in 50% of cases, a relative hypertrophy of left lobe in 81% of the cases. In most of cases, we have normal caudate lobe in these patients. Splenomegaly is found in 90 to 100%. Periportal and perivascular fibrous thickening are variable, up to 3 centimeters. There is an absence of ascites and nodules, and normal liver function. On the right side, we can identify a liver with relative hypertrophy of left lobe, and we can identify the thickening fibrous perivascular and periportal, like you can see here. In 73% of the cases, portal vein with normal speed in schistosomiasis. The arcuate hepatic veins with multiphasic pattern, and 6% of portal vein thrombosis caused by low flow rate is related to the bleeding of esophageal varices. Here we can identify different features of thickening of fibrosis close to main portal vein and branches here, and here on the right. Cirrhosis. Cirrhosis, there are many causes of liver cirrhosis, and the varices, cirrhosis B and C, and alcohol can cause this pathology. In these cases, we can see the macronodular cirrhosis on the right, where we can identify small nodules, and on the right, the micronodular cirrhosis, that the appearance of B-mode ultrasound in this case is close to be normal. In liver cirrhosis, we have nodules caused by regeneration and hepatic carcinoma. In spleen, splenomegaly and gamma-Gandy nodules. Cholelithiasis is associated in 30% of the cases. In most of cases, we have ascites. Low flow rates in portal vein, different from schistosomiasis. Hepatic vein has monophasic flow. Complications secondary to chronic liver disease. Portal vein thrombosis. You can identify acute portal vein thrombosis, chronic portal vein thrombosis. It can be spontaneous, post-surgical thrombosis, low flow rate thrombosis caused by esophageal varices, and tumor caused by hepatocellular carcinoma. Now you have different examples of portal vein thrombosis. On the right side here, a small branch of left branch of portal vein with a partial thrombus inside. Here, a partial thrombosis of splenic vein and main portal vein. In these cases, we can, on the left, you can identify a tumor thrombosis, and this finding of the tumor inside the portal vein with a flow, arterial flow with low resistance, intratumoral flow in this case. On the right, a partial thrombosis, a chronic partial thrombosis with some calcifications inside, and in the left branch in a patient with schistosomiasis. Evaluation of collateral vessels. Using Doppler sonography, we can identify paraumbilical vein, left gastric vein, short gastric veins, splenorenal shunt, hemorrhoidal plexus, and the esophageal system. Left gastric vein, close to the border of left lobe, we can identify the left gastric vein or the coronary vein, and here is the main portal vein. As you can see in this picture, this is the left gastric vein. Now you can see a case of portal stenosis and left gastric vein post-liver transplants. On the left side, we can identify a portal vein lung stricture at grayscale and Doppler. And on the right side, the same appearance on color Doppler. Collaterals from portal vein at coronary vein site are identified close to the border of the left lobe on the left and on the right. This is a short video clip showing these collaterals from portal vein at coronary vein site. This is the angiographic appearance of these collaterals here, and the stented portal vein without the structure. A 3-day post-stent evaluation showing the main portal vein with the stent, a normal flow at post-stented portal vein, and there's no flow in the coronary vein and intrahepatic collaterals. This is a video clip showing the normal flow at portal vein and no collaterals identified in this case. Paraumbilical vein is another collateral pathway in cirrhotic livers that comes from the left lobe branch of main portal vein. The hemorrhoidal plexus and retroperitoneal plexus can be identified close to the spleen and the lower pole of the left kidney. This is the appearance of retroperitoneal collaterals and the appearance of the same case in this tomography. Here, the vessels that goes to the hemorrhoidal plexus. A splenorenal shunt. You can identify the splenorenal shunt using Doppler ultrasound close to the spleen and the left kidney, as you can see in this picture, or using the same approach of tomography and MRI. In this case, we have the MRI appearance here and the appearance of splenorenal shunt in B-mode grayscale ultrasound and on Doppler. Esophageal varices. We can identify in some cases esophageal varices close to the border, the inferior border of left lobe, and close the esophageal. Here we can identify the varices close to aorta and inferior vena cava. Cystic varices. This is another pathway of collaterals. In this patient with schistosomiasis, we can identify on color Doppler these small branches of blood vessels and the comparison with computed tomography. Here is another case of cystic varices in a patient with liver cirrhosis on grayscale ultrasound and color Doppler. Budd-Chiari Syndrome. Budd-Chiari Syndrome involves the hepatic vein or IVC thrombosis. There are many causes of Budd-Chiari syndrome, and myeloproliferative disorders are more common. Involvement of one main hepatic vein may be asymptomatic in some cases. The forms: fulminant, acute, subacute, or chronic forms of Budd-Chiari syndrome. Thrombosis and fibrosis of the hepatic veins can be partial or complete in one or in all the main hepatic veins. The velocity and intensity of thrombosis define, in some cases, the severity of symptoms, and portal hypertension in these cases is identified by refractory ascites, hepatic failure, and esophageal varices. Acute form of Budd-Chiari syndrome is the hardest form. On grayscale ultrasound, we can identify the increase of the caudate lobe, ascites, heterogeneous hepatomegaly, and renal failure. On color Doppler, absence of flow in the hepatic veins and IVC. In some cases, portal vein thrombosis is a bad prognosis for these patients. Here is a case of acute Budd-Chiari syndrome in a patient with thrombosis of the right main hepatic vein. Chronic form is the most frequent presentation. Complications of portal hypertension determine the prognosis. Death in 50% of cases in 2 years. Its variable clinical presentation according to the number of the vein involved and the development of collateral vessels. In some cases, chronic forms is difficult. The differential diagnosis of cirrhosis. Chronic form sonographic findings. Caudate lobe hypertrophy is identified in 50% of cases, and it's also present in patients with cirrhosis. Increase in caudate lobe vein diameter. If greater than 3 millimeters, it's a sign of Budd-Chiari syndrome, chronic form of Budd-Chiari syndrome, with sensitivity of 50% and specificity of 94%. Reverse flow in the main portal vein and branch due to the obstruction of hepatic vein. The drainage pathway is the main portal vein. In this case, we can identify the reverse flow in the left branch of the main portal vein, as you can see on color Doppler and pulsed Doppler in the lower left side. Here, the hepatic artery is hepatopedal, and the left branch of main portal vein, you can identify the reverse flow. The intrahepatic collaterals is the most sensitive diagnostic sign. It's present in more than 80% of cases. Doppler and B-mode ultrasound is the first line to diagnosis. Extrahepatic collaterals are identified by computed tomography and MRI. Collateral vessels. Intrahepatic collateral vessels are identified in these cases, as you can see on the right, there's the comma collaterals, the hockey stick collaterals, and the spiders here. In the short video clip you can identify some hockey stick and comma collateral pathways. Some subcapsular collateral pathways. Close to the border of the liver. Small collateral vessels close to IVC. In this case, we can identify these vessels close to their normal hepatic vein, and here the collaterals close to the IVC with a portalized pattern of blood flow. In this case, we can identify the hypertrophy of caudate lobe, different collaterals in the left lobe, and these collaterals in the right lobe with color draining to the IVC. In this case, we have the Budd-Chiari Syndrome of the right hepatic vein and the collateral coming from the right lobe to the left lobe. Here is an example of post-transplant stenosis of hepatic vein with short intrahepatic shunts from the middle to the left hepatic branch. As you can identify and color Doppler, and in the angiography study, the short intrahepatic shunts from middle to the left hepatic branch. And here the normal findings of left hepatic vein. Cardiac liver is caused by passive congestion of the liver. We can find homogeneous hepatomegaly, dilation of IVC and hepatic veins, ascites, and in some cases heterogeneous texture and cirrhosis. Multiphasic flow or monophasic flow can be identified. This is a case of cardiac liver where we can identify the IVC, the reversed flow in the main portal vein, in the main hepatic veins, intrahepatic arteriovenous shunts. Spontaneous shunts can be identified by B-mode ultrasound or Doppler color. In this case, we can identify two small shunts in the left lobe of the liver. These shunt, and another one with color Doppler. Here is another case of aneurysm of portal vein and its branch, identified in B-mode ultrasound and color Doppler. Transjugular intrahepatic portosystemic shunt, evaluation with Doppler sonography. TIPS is an interventional procedure using a self-expanding metallic stent set through transjugular access. It reduces pressure in the portovenal system, decreases complications secondary to hypertension due to the ineffectiveness of other forms of treatment. Indications: refractory esophageal varices in 10% of cases, refractory ascites, Budd-Chiari Syndrome, and the bridge as a bridge to transplants. Doppler sonography is useful for TIPS before TIPS to see the patency of portal vein and main branches, the hepatic veins, and IVC, the flow direction of these branches. Collateral vessels can be identified using Paraumbilical vein and left gastric vein, ascites, hepatic nodules, and anatomical variations. This is the methodology of TIPS. Here you can identify the right hepatic vein, and here the stent close to the portal vein and the right hepatic vein. Complications. The main complications of TIPS is stenosis. Normal parameters: pulsatile flow, turbulent flow in the stent in some studies, increased velocity in the tips from 90 to 190 centimeters per second. Velocity is similar inside the stent. An increased velocity in the portal vein. In most cases, portal vein branches drain into the stent. We can identify the stenosis in the proximal third, in the middle third, and the distal third of the stent, or the stenosis can be a diffuse. The importance of TIPS stenosis is because 30 to 40% of patients are asymptomatic. Doppler is a non-invasive method, can identify the anatomical variations, and can guide the procedure. There are many parameters of stenosis in the literature. An increased velocity at the site of the stenosis, a decreased velocity in peristenotic velocity, continuous flow in the stent, the velocity in main portal vein less than 30 to 40 centimeters per second, a decrease of velocity in main portal vein, and velocity gradient inside the stent. Stenosis at distal third, pseudointimal hyperplasia, turbulent flow at the junction between the stent and hepatic vein in 70% of cases. This is an exam, the first exam where we can identify a velocity of main portal vein close to 50 centimeters per second, a normal velocity in the proximal third of tips, in the medial third and the distal third of tips. In the follow-up 8 months later, and the patient's asymptomatic patients, we can identify the reduced velocity in the main portal vein and an increase of velocity in distal third of the tips, close to 230 centimeters per second. In the angiographic study, we identified stenosis in the distal third of the stent, treated by using another stent inside, and the first exam after angioplasty, the flow come back to the normal parameters. The portal vein velocity is close to 40 centimeters per second, and similar velocities in the proximal, median, and distal third of the stents, close to 200 centimeters per second. Stenosis of the proximal and middle third can be caused by intimal hyperplasia, biliary fistula secondary to state placement, and in 24% of cases occurs in the middle third. Few cases in portal extremity, more symptomatic, greater incidence of bleeding. This is an example of stenosis of the middle third, where we can identify on color Doppler and the pulsed Doppler the place of the stenosis. Here is the angiographic confirmation of this stenosis, treated using angioplasty and another stent inside the tips. The Doppler control after angioplasty identify the pulsatility flow in the middle third, proximal third, and distal third of the tips. This is a case of stenosis at the portal extremity, where I can identify a high velocity in the portal extremity, close to 300 centimeters per second. In our experience, we use as a velocity inside the tips for stenosis at 230 centimeters per second. The velocity in portal vein, in the main portal vein, is normal, around 51 centimeters per second, and less than 26 centimeters per second is the sign of stenosis. The gradient between 2 points in base exams vary from 0.5 centimeters per second to 88 centimeters per second, and in cases of stenosis varied from 110 centimeters per second up to 400 centimeters per second. Contrasted enhanced ultrasound in tips. Here we can identify the appearance of tips in these cases with in normal contrast enhanced ultrasound in normal tips and in cases of we find the stenosis. This is one case of stenosis in tips, a low velocity in main portal vein, the pathopital flow in the left branch of main portal vein, a low velocity at proximal third of the tips, close to 26 centimeters per second, and in the middle third we identified a velocity of 478 centimeters per second on Doppler ultrasound. In this case, using contrasted enhanced ultrasound, we identified the tips here and 2 points of stenosis in the middle and in the distal third of the stent. As you can see here. And in some cases, tips and contrasted enhanced ultrasound is useful to evaluate the junction between the right main hepatic vein and the IVC close to the right side of the heart. In this case, we identified a high velocity in the middle third of the tips and the normal appearance using contrasted enhanced ultrasound. In this case, we identified using contrast enhanced ultrasound the IVC, tips, and the right hepatic vein. In conclusion, it's important the knowledge of the hemodynamic aspect and variations based on basic tests and follow-up tests using multiple parameters for tips evaluation and attention to the absolute values of velocity. Angiography is reserved for treatment, and microbubble contrast agents improve sensitivity and specificity in some cases. The summary: suspicion of the pathology, the type of the study to be performed. We can identify the B-mode signs, a careful Doppler evaluation with special attention to the vascular territory of the interest, guide further investigations with MRI, CT, or medical decisions. Okay.